Good afternoon. Many thanks to the THS for this forum. I'm very happy to be the first speaker, and I'm going to share with you the idea of translating the integration of communicable and non-communicable disease research findings into practice in our healthcare delivery system. Next. Yeah, so we are all aware that there is a convergence of communicable and non-communicable diseases, and we are witnessing a lot of morbidities and the mortality around these challenges. Communicable diseases are well organized. TB, HIV, they have well organized care delivery systems. Now the question here is, can we integrate communicable diseases and the non-communicable diseases in our healthcare delivery systems? Is it possible in a sustainable manner? So just wanted to reflect back next. When we were doing education, starting with the primary school. Next slide, please. When we were doing education, at one point, yes, next slide, can you advance? Okay, thank you. When we were doing our education, if you remember, at any time t, there were some mathematical equations which they were impossible, as you can see below line. For example, 2 minus 5, for those who remember when we were in standard 2, it was impossible. Square root of 8, when we were Form 1, it was impossible. Same with the square root of 4, for those who went for mathematics, it was impossible. However, if you do some workout to make sure it's possible, you see there are a lot of computation. So we should also think this, we should think the same, that we want to integrate and we need to work out to make this integration possible. So I call everyone to advance the classes to ensure we think in a possible way. Next, yeah. So Kibongoto and the colleagues, including Hindu Mandari and the other colleagues here in Tanzania and of course outside the country, we tried to solve the equation. And we started with the gap. The gap was, there is underdiagnosis of communicable diseases. There was underutilization of available diagnostics. And we used TB and diabetes mellitus as a case study. So despite the fact that glucometers were available, but they were not utilized to screen patients with the TB. However, evidence shows that TB and the diabetes is common, and for example, in Mwanza, they showed the mortality was 5-fold. But despite all the fact, people were not, they were underutilizing the available diagnostics. Another challenge, we observed that there was lack of mentorship, and actually this came from the healthcare providers. We did a focused group discussion, and they said we don't get adequate mentorship to address this challenge. They also mentioned that there is inadequate competence and the skills. In addition, they mentioned that there is there is negligence in terms of implementing the clinical standards in our clinics. And it seems, apart from rampant negligence which was existing, there was no accountability and the leadership in our healthcare delivery system to push these things forward. And so with those kind of elements which we learned from our healthcare delivery system, we actually drive the theory which we highlighted the next step to address some of the elements. For example, to show the mentorship and the leadership, we engaged medical specialists and also nurse officers to champion this integration. Number 2, we designed the training models into 2 steps. We call this stepwise training to reinforce knowledge and skills for the bidirectional care. And also we added an element of clinical audit to ensure we put an element of accountability. So all these, we were focusing to increase knowledge and the hands-on skills to implement the task, create leadership, but also an accountability using system framework. Next. Yeah, so as you can see, 2 elements we are driving our our main agenda of integrating communicable and non-communicable diseases. The stepwise training approach and also the learning system, which is a clinical audit. And it's not like once you exercise this, you have done. No, it needs to be regularly implemented. Next. And we prepared the material to test for stepwise training because we wanted to see, is it feasible, is it acceptable? And we tried to pilot it in urban, semi-urban, and in rural settings. Next. This is an example of the group. And those who are senior, the medical specialists and nurse officers, they are the one who attended the level 1. Apart from doing online web-based training, we added a workshop and we used what we call Gibbs reflective cycle to cement their understanding and the knowledge. So the details of the Gibbs reflection, which is a mechanism to ensure someone is able to exercise the knowledge which they have taught. And also it was like exposing them to available tools and diagnostics after they have gone through the web-based training material. Next. Fortunately, at that time, there was a clinical audit. So we tried to design the clinical audit, and of course, we identified the areas which we highlighted for clinical audit, and we put the rationale, as you can see. Next. Now the findings of what we learned. Next, sorry. Yeah, so we started with 46 medical specialists or doctors and also nurse officers. They were exposed to web-based training, and of course some didn't attend, and someone who didn't attend means we excluded them to come for the workshop. It was also a motivation for someone to pass the web-based material. And later, after the workshop, we told them to go and exercise in their locality, within the regional. They served as TOT in the regional. And as you can see, we started with 46, but we ended with 31 experts or practitioners who were available to support the others. There were many reasons why those others didn't participate. And the next step, it went to 519 who were able to train. So you can see, out of 18 nurses, they supported like 371 nurses, and 13 medical officers, the step 2, they supported like 118. Next. Yeah. So the issue of everything was acceptable, feasible. Most of the providers were interested in this approach. Next. Yeah, so generally, because our dashboard was TB and diabetes mellitus, you can see those P values which were significant. They were the changes of the practice. For example, we wanted to see screening of DM in TB, was it working well? It was working well. That's why we see there was a considerable difference. And vice versa, it was also working well. The other parameters needed a push because some of the clinics didn't have some weight machines. They didn't have, they were not supposed to measure height, but we know there are a lot of changes currently. It might be possible. Next. So to simplify our equation, that it is possible to integrate in a sustainable way, but we have to incorporate the digital technologies. We have also to create a strong teams which can own the agenda within the region, and also implement the clinical audit as a mechanism for continuous improvement. You know, with the clinical audit, if you expose score, usually people, they don't want to be in the list. Yeah? Everyone wants to be among top 3. So if we put clinical audit as a mechanism and you create like a transparency, everyone will struggle to ensure they score well. Yeah, so to that end, I would like to thank for your attention.
Please put your hands together for Professor Stella, my sister. Thank you so much. That was a presentation on translating the integration of communicable and non-communicable disease research findings into practice in the healthcare delivery systems in Tanzania. That is experience from Kibongoto Infectious Disease Hospital, presented by Professor Stella Mpagama. Thank you so much. I would like to remind our audience, please note down any questions or comments or thoughts that you'd like to share in this forum. Please write it down on a piece of paper and raise your hand. We have 2 facilitators, Dr. Ola and Dr. Tarimo, who will come and collect it from you for compilation and sharing during the Q&A session. Please, let's try and do that for the sake of managing time well. Our next speaker is my teacher, disclaimer, Professor Kaushik Ramaiah. He is the president of the African NCD Network. He's a board member of the World Diabetes Foundation. He's the honorary general secretary of the Tanzania Diabetes Association and the Tanzania NCD Alliance. He's the president-elect of the East African NCD Alliance and a board member of the Global NCD Alliance. Professor Ramaiah served as chair of Sub-Saharan Global NCD, Sub-Saharan Africa region for the International Diabetes Foundation from 2000 to 2006, and then as global vice president for the same from 2007 to 2012. He was appointed honorary professor for medicine and global health at the Liverpool School of Tropical Medicine since November 2018. Professor Ramaiah greatly contributes to the better understanding of diabetes in the Africa region. He has also investigated on the status of diabetes care in Africa, the economic cost of diabetes, and its consequences. At present, Professor Ramaiah is working with children who have type 1 diabetes, gestational diabetes, metabolic syndrome, and cardiovascular complications of ARV treatment in HIV and TB diabetes interactions. Together with the National Institute for Medical Research and the London School of Tropical Medicine, he's working on communicable and non-communicable disease integration models, and he's also overseeing the metformin intervention in people living with HIV with IGT. He has also participated actively with other colleagues in the Tanzania Diabetes Association, the Ministry of Health, and TAMISEMI to implement the Diabetes NCD program at zonal, regional, and district hospitals across the country. This program has now obtained additional funding to expand to encompass NCD prevention and promotion, curative services in primary care, training, policy and legislation, monitoring and evaluation, and operations research. Please put your hands together for Professor Kaushik Ramaiah. Karibu, Prof.
Thank you very much for that introduction. My task today is to talk about bringing private and public partnership for prevention of NCDs and establishing the integrated model. So my presentation has been divided into two different sections. One is looking at what we are doing on component of prevention as Tanzania Diabetes Association and Tanzania NCD Alliance. And second thing, we are looking at different models of integrated care. So, yeah, so basically if you look at the overview of the health landscape in which we are dealing with, we have got a double burden of infectious and non-communicable disease. There is a very important component of collaborative approach which is required between the private and the public sector. And Tanzania NCD Alliance and Tanzania Diabetes Association is actually bridging that partnership for effective prevention of risk factors and burden of NCDs. And our focus is mainly on community sensitization and advocacy as the key strategies. So why there is a need for having a private-public partnership? One, we want to leverage the resources. We want to combine the strengths of the public and the private sector for broader impact. And we want to have a successful PPP program, just as insulin distribution, which we do for more than 6,000 children in the country with type 1 diabetes, healthcare providers training, establishing NCD clinics at different levels of healthcare, and also doing advocacy and awareness campaigns. We are also addressing the gaps, which are basically filling the gaps in funding, providing infrastructure support, and expertise through the partnerships. And we are looking for a long-term sustainability while working with the ministry to ensure that once the programs have got a good model, then they can continue. Sorry. So just to remind you, for many of you, probably you know this chart, but this is basically Yeah. So this is basically looking at the risk factors, and if you look at the genesis of the non-communicable disease, I'm sure many of you know about it, but just to remind you is that what are the risk factors we are looking at. Previously, many of you know that we were talking about 4 by 4, now we are talking about 5 by 5. And we are talking about unhealthy diet, physical inactivity, tobacco use, harmful use of alcohol, and environment has been added. And when you look at the 4 major diseases, you're talking of heart disease, you're talking of stroke, cancer, chronic respiratory disease, diabetes, and now the mental health has been added to that component. So we have got basically 5 by 5 component now, and we are looking at targeting how do we actually work on this risk factor profile. So if you are able to work at these common modifiable risk factors, and if you are able to do prevention within these modifiable risk factors, then you're down the road where you develop excessive blood pressure, you develop high blood glucose, you develop high lipids, overweight and obesity, resulting into the disease factor does not take place. I've also added this, this is from the global burden of disease, and just to highlight why air pollution and environment is now becoming a major issue, because if you look at the total number of deaths from 2019, high systolic blood pressure is number 1, tobacco is number 2, dietary risk factors and nutrition is number 3, air pollution is number 4, then you have high blood glucose, which is number 5, body mass index, which is number 6, dyslipidemia is number 7, renal dysfunctions, kidney disease is number 8, then you have malnutrition, and then you have an alcohol use. So you see that if you are able to control the risk factors, then you are able to change the end game of what the burden of the disease is going to be. This is a STEP survey which was done in 2012. It is about 12 years old. A new STEP survey has been done. It has been completed. It's awaiting final ministry's approval for the release of the data, which has been done after exactly 10 years. But what you see here is that what you see is that the physical activity, the level of physical activity, the physical activity level is basically mainly it is related to the work. Transport related is 21%, but the recreational physical activity is only 5.9%. And if you look at heavy episodic alcohol users, it's 27.4 for male and 13.4% for female. And again, poor dietary intake is basically contributes 97% of the poor nutrition. And it was interesting walking down the lunch hall today. Many of you, when I was walking down the hall, many were looking at me that what they were eating in their dishes, unfortunately. So I avoided going to the lunch hall because I think I would have stopped many of you from eating. So I think what is important, three main messages in this chart. One, I think we are eating poorly. Second, we are not doing physical activity. And 3, we are drinking a lot of alcohol. And from the recent world report, we are probably in the African region, we are number 3 in alcohol consumption, and after Seychelles, Uganda, and Tanzania. And then per capita, the high alcohol, pure alcohol per capita consumption is highest in Tanzania. So you can look at what risk factors we are looking at. Again, if you look at high prevalence of hypertension and diabetes, you find that basically 26% of the people have high blood pressure, more than 9.1% have diabetes, and you find that basically 33% of all the deaths are attributed to the non-communicable disease. So you find that we have a problem. Probably the new data from the steps in 2023 will tell us exactly whether we are going in the right direction or we are reversing the trend. That will give us a 10-year overall picture. So what are we doing as a Tanzania NCD Alliance and TDA? We are doing community sensitization and outreach activities. We are going and educating the communities on the lifestyle risk factors. We are doing various platforms to do it, and we do community screening wherever there are gatherings. We do a lot of advocacy work. We do a lot of policy implication. We work the parliamentary forum on NCD. We work with the ministries. We work with the different stakeholders to ensure that the policy takes priority, and we also make policymaker sensitization. We also do the training component, which is in a cascaded manner, and we also develop a lot of IEC material, which is basically related to a non-communicable disease. And we have a booklet which has been published, which is known as Mtindola Bora wa Maisha, and this is basically a Kiswahili book, which is actually expounding all the diseases, non-communicable diseases in Swahili language with all the risk factors, and it is freely available and freely you can download it. So what are our key focus areas? One is physical activity, 2 is nutrition, 3 is tobacco, and 4 is alcohol. We have been working on physical activity. We have had a physical activity guideline, which is awaiting final authorization to be released. We have been working with the Tanzania Food and Nutrition Center and National Nutritional Policy looking at nutritional components. Tobacco has been a challenge. It will always be a challenge. And alcohol is something which we are now working on. We have basically created an MP forum for advocacy and policy dissemination. We have actually strengthened the council health management teams and health management teams to provide supportive supervision. And we have managed to get through the ministry and the local government a regional and NCD coordinator in each and every region and the district. We also got the capacity building and job description of these NCD coordinators. We have currently we have actually done 187 district hospital training, setting up the diabetes services, NCD services, which is comprehensive. We have expanded type 1 diabetes clinic from 36 to 63 clinics, and now we have also included the health centers into the component. We have improved the accessibility of children with type 1 diabetes, community education, empowering media, and also working on the digital platform. So when we come to basically strategies, as we said, we have got various different strategies in place to look at how we can actually decipher and work on prevention, but at the same time early diagnosis. Overall, we have been basically successful in making sure that the advocacy programs go for. What is the long-term future? We have got an ongoing support for both public and private partners. We are replicating successful PPPs, and we are actually looking at sustainable solutions to how we do the advocacy and prevention. We are also looking at different policies. We are looking at different policies of physical activity, looking at nutrition policy, looking at food environment, food system and behavioral change, and we are also looking at the global health and development priorities. So if you look at the global health and development priorities, you find universal health coverage is number 1, non-communicable disease is number 2. And what we are doing is trying to focus within the global priorities of how we move forward and what are the possible agencies with which you can work. And if you see within the NCD, there's hardly any donor agency which wants to touch a base on non-communicable disease. So what is the solution? Solution is trying to see how we can actually bank on other programs, trying to see how we can integrate those programs within the existing programs where the funding is equally available. If you look at this scenario, if you see the condition HIV in 2023, in 2003, there were 25 million living with HIV, less than 5% were controlled. There were 3 million new cases and 2.3 million new deaths. If you see the current HIV atlas, you find there are 39 million living with the condition. More than 80% of them are well controlled, and only less than 1 billion are dying. But if you look at diabetes and if you look at hypertension, you can see the numbers which are showing that there is actually a much larger burden which you see in these individuals. So what's the solution? Solution is to try to integrate. And how do you integrate? And if you see within the HIV programs, this is from the statistics from the African region, and if you see people with HIV, the hypertension dyslipidemia is around 20 to 22%. Dyslipidemia is more than 68%. And these individuals are now dying of non-communicable disease. So what do? We do an integration, which is also being proposed by UNAIDS. This is a slide from UNAIDS, which shows that how at each level of HIV prevention, HIV testing, at linkage with the treatment, care and treatment, how can you link your NCD component within the existing patient pathway? And then you've got different models of care. You've got at primary care, you've got a one-stop clinic whereby you can provide an integrated care. If you come to a secondary level, at the district hospital or regional hospital, you can have a swapping between the clinics, while if you go to the zonal hospitals, you've got a standalone clinics. And you need to look at what is the scientific validity of each of these models and how do you work out. And this is something which is work in progress. We are also, within our health centers, where we are doing a common triaging component. And this common triaging basically looks at any patient who comes, undergoes all comprehensive screening, trying to see whether we can pick up the multimorbidity within these children and with these individuals who come in. So with that one, we are also looking at the global best buys by WHO. This is my last slide. And we are looking at how we can actually do the cost-effective interventions and looking at different models of care. With that one, I just want to end by saying, currently we are spending a lot of money in secondary and tertiary care, very minimal money in prevention, while we should be focusing more on prevention and minimally in secondary and tertiary care. Thank you very much.
Thank you so much. So much to share from Professor Kaushik. Sustainable models for prevention and care of communicable and non-communicable diseases, looking at public-private partnerships for the same. Let me invite our next speaker, Dr. Edem Tambatia, who is the founding and current executive director of Tanzania Health Promotion Support, THPS, an indigenous NGO that was established in 2012. She has altogether over 42 years of professional experience in clinical medicine, public health project management, research, and academia. Across the years, her professional focus has been in donor-funded public health project management and research focusing on HIV and tuberculosis prevention, care and treatment, maternal and neonatal health, sexual and reproductive health, gender mainstreaming, HIV prevention, treatment and harm reduction among key and vulnerable populations, malaria and non-communicable diseases, health, lab and information system strengthening, and responding to epidemics, including COVID-19. Such projects and public health evaluations received funding from PEPFAR, US CDC, USAID, NIH, the Bill and Melinda Gates Foundation, World Bank, the Global Fund, UNAIDS, US-based universities including Harvard, Columbia, and the University of Minnesota. She has supervised implementation of over 20 grants, donor-funded programs targeting areas. Hello? Okay, I'll try and shout. So she has supervised over 20 donor-funded programs targeting the areas highlighted above across the country and in communities and in over 700 healthcare facilities. Dr. Mbatia is experienced in working in partnership with governments and the public sector through the Ministries of Health in mainland and Zanzibar, local government, the Ministry of Home Affairs, the local and international NGOs, and in implementing public health programs to ensure high impact and efficiencies in resource-limited settings. She is skilled in policy development, starting up and scaling up public health programs in underserved areas through strategic planning, project oversight, research design, and health facility and community system strengthening. Dr. Mbatia maintains regular communication with government ministries, donors, and other key government and non-governmental partners, and she represents Tanzania Health Promotion Support in national and international fora. Please put your hands together for my boss, Dr. Mbatia.
Hello. See.
Or rather, we have a base of about 180 recipients of care. And when we started embarking on integration, our screening rates for hypertension, I remember last March, was only at 52%. But the slide you see in front of you shows that by August this year, our screening rate of all those clients who come to the clinics is 95%. And out of them, about 2% have been confirmed to have high blood pressure, and 81% are linked into both lifestyle modification and pharmacological treatment, while the remaining 20% are only on lifestyle modification because they have mild hypertension. But one thing I would like you to note is it is actually possible. This is a regular routine program, and as you can see, Shinyanga has been doing very well, and 91% of their clients who have been diagnosed with hypertension are actually on medication in addition to lifestyle medication. Next slide, please. So now going into a demonstration project that we are implementing under the same project. We have focused now to 8 health facilities in Kigoma and Pwani. Next slide. To see how can we actually implement this integration and eventually scale this up. So we are working at 8 primary healthcare facilities, as I said, in Kigoma and Pwani, representing both rural and urban centers, and the service provisions that we provide includes comprehensive person-centered HIV prevention care and treatment, assessment of nutritional status, management, that is screening for hypertension, conducting baseline investigation, and providing pharmacological treatment in addition to lifestyle modification for those who are eligible. And we also conduct follow-up integrated services of hypertension for those who have hypertension, and try, once they have stabilized, to align their visits to the HIV drug pickup. So health education on lifestyle modification is provided by lay counselors or the peer educators who are already at the clinics providing health education and promotion on HIV and tuberculosis. Our goal is to expand the lessons learned from this pilot to other facilities that we are implementing. So when we started this early this year in March, we sensitized the regional and district health facilities, health management teams, and we actually deployed 8 clinicians, all of them clinical officers, 1 per each facility, and trained these clinicians together with all the other providers working at the clinics on NCDs and HIV integration using the Ministry of Health approved tools, which I'm very proud to say that Professor Kaushik was one of the persons who worked on them. So to enhance their skills, there is ongoing mentorship and supportive supervision together with the regional and district health management teams. Next slide. Now, just to show you our progress, on the left-hand side of the slide, you can see that the cascade by age and sex. When you look at the females, first of all, on average, the screening at these 8 facilities is almost universal. 98% of the recipients of care are screened for high blood pressure, and we have confirmed 4% of them being hypertensive. And as you can see, females have a higher burden of hypertension already from the age of 50, compared to male who have a burden of 7% from the age of 60. On the right-hand side of this slide, I just want you to show that of all those who have diagnosed to have hypertension, 30% were already known, but twice as much, 70%, are for the first time newly diagnosed as hypertensives during their visits to the HIV care and treatment clinics. Next slide. Now, looking at the funding modalities and follow-up visits of at these 8 sites between March and August again, majority of the clients we serve in these 8 clinics receive their antihypertensives from the demonstration pilot. So we are funded to provide the drugs. And then about 15% of them receive exemptions from their health facilities. However, less than 1% get their drugs through the national health insurance, and about 1.5% are actually paying out of their pocket. Below this slide, I would like to just share that of the 98 clients who have had 3 and 6 months follow-up, 58 of them have actually stabilized with their hypertension, and almost all of them have had their visits aligned. So they only come for ARVs and antihypertensive refill at the same time. Looking at next slide. Next slide, please. Looking at the coverage of baseline laboratory investigations at the demonstration sites, during the same period, we have been doing this well in Pwani, with 90% of the clients receiving urinalysis, blood glucose, serum creatinine, and lipid profile done as part of the investigation. However, the follow-up investigations are not funded by the projects. Kigoma was lagging behind, but these clients are being followed up. Next slide. So just to conclude, and this is my last slide, we just demonstrated that it is possible to align NCD management within existing HIV service delivery models at primary healthcare facilities. And we also realize that you need additional resources to provide the antihypertensives. You can see the cost of antihypertensive ranges between 15,000 and almost 30,000. But we can rely also on other resources to fund the antihypertensive. The only problem we have a very low coverage of health insurance scheme. This is less than 1%. So to finish up, we just see that there is an opportunity for intensified screening for NCD, and we need to focus more on prevention, just to reinforce what Professor Kaushik said, and through lifestyle modification, so that will decrease the burden of hypertension. And finally, there is an urgent need to operationalize the universal health coverage and the universal health insurance. I would like to, next slide please. I would like to finish by acknowledging our donors and our counterparts at the Ministry of Health and the TAMISEMI. Thank you very much for your attention.
Hello. Thank you so much, Dr. Redempta. We really congratulate you on trying to even overcome the technological challenge. So that was, we heard about the experience of Tanzania Health Promotion Support in integrating HIV and hypertension detection and care at HIV care and treatment clinics in Kigoma and Pwani. And we look forward to your insights and questions. Again, I'd like to remind our audience, if you have questions and comments or thoughts, please write them down and raise your hand for our 2 moderators who will collect those questions and comments for compilation so that we can have an efficient and effective Q&A session. Now we transition to the private sector. Our next speaker is Dr. Ismail Gatalia, who is a dedicated medical professional with robust background in healthcare management and clinical practice. Currently serving as Strategist Insurance Tanzania Limited, Dr. Gatalia plays a pivotal role in designing and implementing health strategies that enhance patient care and outcomes. His experience and expertise spans both communicable and non-communicable diseases, with a particular focus on integrating prevention and care within health insurance frameworks. Dr. Gatalia is passionate about fostering collaborations between public, private, and NGO sectors to create a sustainable healthcare model. In this forum today, he will be contributing his insights on how the healthcare insurance companies can effectively partner with other sectors to improve disease prevention and management across diverse populations. Dr. Gatalia holds a medical degree from the Catholic University of Health and Allied Sciences, a CII from the Chartered Insurance Institute, and he's currently pursuing a Master of Science in Insurance and Actuarial Sciences from IFM. He has 9 years of experience in the medical field with a focus on managing complex health insurance plans and ensuring effective medical service delivery. Please join me in welcoming Dr. Ismail Gatalia. I didn't get your presentation, so it's not on my computer, but it will be showing up. And this is for advancing the slides.
Good afternoon, everybody. Once again, thank you for this opportunity. I would like also to recommend my the previous presenter, Dr. Kaushik, Professor Kaushik, Professor Stella, and Dr. Redemptor. My insight in this is just to show the burden of NCD in terms of funding and financing. So I'm just here as a insurance specialist, both in health and medical insurance, and try to give you a glimpse of how the burden is in terms of funding this NCD. So I'm gonna just introduce you to healthcare and financing. I know a lot of you may know, but we'll just we'll have a glimpse of what healthcare financing is. Number two, we'll try and show the impact of non-communicable diseases on insurance claims. Insurance claims is where the expenditure are. So whenever anybody who is holding a medical insurance card, what you are going to be billed is what we call a claim to us. So this is where the money goes. And we'll try to show how much of what you're spending, how much we are spending on non-communicable diseases. And then we'll try also to show the role of early detection and prevention. I know Professor Kaushik has spoken on the prevention side. Also, Professor Stella also spoke about the prevention side. Now I'm going to bring you to see, I'm going to take you and see how that can really affect or decrease the claim cost in terms of insurance. So once again, health financing is just a flow of funds from patient to healthcare provider in exchange of medical service. The main source of fund basically for direct government financing. This is the basic co-funding. Then followed by health insurance, which is both public and private insurance. Currently, the public insurance holds a bigger portfolio compared to the private insurance. Then there's out-of-pocket payment, there are donor funding, and voluntary contribution. So again, healthcare finance is the key to determine the health system performance in terms of equity, efficiency, and quality. So without funding, all that we've spoken earlier cannot go. And now, when we want to see the impact of NCDs in the insurance perspective, number one, you need to understand that insurers look at the risk. And what is risk? Risk is basically a product of probability and impact. So if me as a health expert of insurance, I'm going to look at what risk an NCD has in terms of claims and what is the impact. The impact here being the kind of funding that I'm going to spend on health insurance. So again, by definition, a simple definition of NCD is that are medical conditions that are not infectious, not caused by infection agent, but can be transmitted from one person to another. Typically, NCDs are chronic, keyword chronic, and progress over a long period of time. So if these diseases are chronic, meaning they have a bigger magnitude, while the time or duration constitute the possibility of the frequency. So meaning any claim that I get from NCD has a bigger risk compared to any other claim. Did you get the concept there? So any person who has an NCD, to me, I consider that as a bigger claim compared to any other claim. So again, risk impact assessment is the process of assessing the probability and the consequence of risk events if they realize. And in this particular framework is the NCDs. Sorry. So the current expenditure and this is from strategies point of view, our own claims that we've done our own analysis and research. 40% of our incurred claims in insurance companies are from the NCD-related condition, mostly contributed by cardiovascular. I know Professor Kaushik has spoken about this. Cancer comes next, diabetics, chronic respiratory diseases, and a mental health disorder. A special note should be taken on the mental health disorder because this is normally not considered in our discussion. So in terms of cost analysis of NCD claim, I'm going to take you in a little bit calculation. So a claim, or a medical claim will constitute these four major things: a consultation, investigation, procedure, and medication. Now, consultation, for any patient who has hypertension or who has been diagnosed with hypertension, there's a likeliness of recurring in cost because you will not have only one visit, you'll have multiple visits. So in an NCD claim, 5% of your claim cost will be from the consultation. 40%, which is also a recurrent cost, because you will have multiple visits, comes from your investigation. A procedure, if it deemed be, it constitutes mostly 25%, and then 30% is the medication, which is also a recurrent cost. So if today I diagnose one client of mine with hypertension, I'm most likely to have approximate expenditure on the first claim of 2 million. Now, if you take an approximate amount of 2 million, 5% of that 2 million will be consultation. That is around 100,000, which is true. 40% of that will be on investigation, and this is recurrent in nature. So if the first visit is likely to get, for me to get 2 million, remember, most of our clients that are being diagnosed in the hospital come in either in the mid stage or the terminal stage. So the expenditure is likely also to increase. Oh, sorry. So what is the role of early detection and prevention? I know Professor Kaushik has taken you through this, so I won't spend much time of it. But overall, wellness programs, which basically is another terminology for our early detection and prevention from insurance perspective, play a significant role in insurance promoting healthier life among policyholders, which are their clients, and reducing overall healthcare costs. 70% of health insurance incurred claim from NCD are treatment costs for cases which are detected late or in terminal stage. Key wellness programs that have impact and are health promotion awareness, screening and early detection, lifestyle intervention, and rehabilitation service. All these programs are very easy to implement, but they really have impact in terms of the cost and the claims from insurance perspective. So after an implementation of a wellness program, this is what we've discovered. 75% of the claim do reduce. So the consultation will reduce, so the frequency will reduce, the investigation will normally reduce significantly. Remember, at the first visit, there'll be normally a lot of screening, follow-up visits, and if they followed by lifestyle, so that will also decrease. Procedures and medication will also decrease. That's all from me. Asanteni sana.
Asante sana, Dr. Gatalia. I misspoke earlier and said private sector. I meant financial sector. So we were listening to Dr. Gatalia speaking to us on the perspective of insurers and the cost of managing non-communicable diseases and the role of prevention in that. Our final panelist for this afternoon is Dr. Prosper Faustin Jau, who is the program manager at the National HIV, STI, and Viral Hepatitis Control Program, popularly known as NASHCOP, under the Ministry of Health in Tanzania. He's a medical doctor and public health epidemiologist with over 15 years of experience. Dr. Prosper has vast experience in designing and implementing programs. He has led the development and implementation of various HIV monitoring, surveillance, and evaluations in the health sector, HIV response. These include the HIV drug resistance survey, HIV drug resistance using remnant blood samples of patients with HIV viremia, the Tanzania HIV Impact Survey, integrated biobehavioral surveys for key and vulnerable populations, and the introduction of HIV recency surveillance and response. Under his leadership, NASHCOP has strengthened the national repository of de-identified longitudinal PLHIV cohort data that has been informative in driving program optimization and patient or person-centered care. Data sets from this repository are also available for research and evaluations. His area of research interest is on HIV care continuity, behavioral interventions design and evaluation, including behavioral economics and HIV treatment adherence, and HIV viral suppression. Dr. Prosper is also an adjunct lecturer at the Muhimbili University of Health and Allied Sciences, and he has authored and co-authored public health reports and over 50 peer-reviewed articles in international journals in the areas of infectious disease epidemiology, looking at HIV, STIs, and health information systems. Please join me in welcoming Dr. Prosper.
Hello. Good afternoon. I'm humbled to stand here today to present, and by the mere fact that the experience and wisdom of my preceding speakers really dwarf my experience, except for you, my brother. Yeah, so today I'll be talking to you about HIV-related HIV aging and related NCD. Next slide, please. All right. So we know that Tanzania is among the highest burden countries in Africa, and in sub-Saharan Africa, Tanzania is the fourth. We are only second to Nigeria, South Africa, and Mozambique. So, and generally, around 1.7 people in Tanzania are living with HIV. The recent survey of HIV shows a significant progress in terms of HIV response and control. 83% of those living with HIV know that they're living with HIV. 98% are using ART, and 94% have attained viral suppression. With this success, however, we still see high HIV incidence, and equally, despite the success, HIV care continuity remains a challenge, and we'll see how the non-communicable diseases compound this challenge. Next slide, please. So our talk today will center on the data that comes from the program data, the sero surveys, and including costing survey that has been done. So this graph shows the trend of HIV prevalence. So we've seen a progressive decline in HIV prevalence, which may be a good or bad sign. We know that if you have a matured ART program, people live longer. We would expect the HIV prevalence to stabilize. But the picture in Tanzania is that the prevalence continue to decline. And one of the reasons why this is happening, because of the success of the HIV program, but also because our population is still bulging. So we have a huge youth bulge that also shows the impact on HIV burden. So this is another graph that shows HIV prevalence by gender, and you can see obviously that women still have, disproportionately high burden. But what is interesting is you can see that the HIV burden now has shifted to middle-aged and older people. And we will see also why, because it is not true that people of our age and a little bit older are the one who gets the HIV infection. But no, we got it in the past and we're still living with it. Next slide, please. So like quickly we can see that even when you look among the survey respondents, the age of those who responded, the average age who responded last 6 years was around 40 years. Now it's around 43 years. So we can see evidently that among those who responded to our surveys, those living with HIV, the age continues to advance. And again, as I've mentioned before, it's not that older people have get more HIV, it's because we are surviving with HIV. Next slide, please. Next slide, please. This compares the previous round and the current round of survey. And as we can see the shift. So this is the peak among females was on around 30 to 39 years old. But the gray one, you see now the peak has shifted to this band. So we are seeing a shift in the burden, and it's not. And again, it's not because, you know, we are getting the new infection, but it's because you are aging with it, and it is consistent both for men and women. Next slide, please. However, when we wanted to look at the data in a different way, so here we're showing the data by the date that the survey respondents were born. And what we can see consistently between the previous survey and the current survey, despite the shift of the burden, we still have an increasing burden in each age category. And it's because while we are successful in maintaining people on treatment, there are still some residual incident HIV infection that occurs along each age group. However, when you look on the far right, then we start to see a slight decline and change in picture. But the picture, what this data shows us consistently, the cohort of people living with HIV is aging. That's one. Next slide, please. Next slide, please. But despite aging, we still have residue HIV infection. And it is highest among the young group. We can see the young group, although it has declined significantly, but still among female, the incidence is very high, which is at around 0.33%. So what we're saying is that the population that is living with HIV is aging, but we still have people who acquire the HIV infection in the population. And actually, what we are seeing is that this number of new HIV infection has declined from what was previously. Next slide, please. Yeah, so again, this graph shows those on treatment below 45 years and those who are above 45 years. And you are seeing a progressive shift. Although this is only 3 years worth of data, but you are seeing a progressive shift from the younger population to the older population. And it's not because we are getting older people infected, but again, as I said, that we are aging with the disease. Next slide, please. So, it is important to understand also the cost because the population continue to live with HIV. In the absence of cure, we expect the treatment to continue for life until when a natural death occurs. And when we see per patient cost for treating HIV is around $180. And given the number of people on treatment right now, so roughly we are spending about 830 billion Tanzanian shillings on HIV treatment alone. Now, with a caveat, the cost for NCDs that I'm showing here is only among the population of people living with HIV who are at risk, which is around, I think, 20%. But what we are seeing is that if we then do integration in terms of HIV prevention and NCD prevention, integrated HIV treatment and NCD treatment, the marginal or incremental cost that we are going to have to fund is about 2 to 6%. And why? Because we already have funded a significant proportion through HIV treatment and HIV prevention. So we stand to reap more if we do an integration. But if it was, so the total equivalent cost actually does not change much. So because of the big figure, When we do integration, it still remains relatively the same. It's still around 830 billion Tanzanian shillings. But if we are not integrating, for the proportion of PLHIV who have NCD, which is around 20%, we will have to pay the 830 plus an additional 3.5 million. Now, with caveat, the 3.5 million is not the cost of NCD care. It is the cost of NCD care among PLHIV, which is very small. Okay, so that's need to be understood. Next slide, please. So, what are the key messages here? We are seeing a stabilizing HIV prevalence, declining and stabilizing. But we are seeing that although the car has reduced its speed, we are still heading in the wrong direction. Yani hata kama gari imepunguza mwendo, kama inaelekea upande usio, hatuwezi kufika safari. We need to turn the car around. And we need to reverse the epidemic, because then the epidemic is endless and we will never be able to sustain, even if we integrate. What we are seeing is that we have a PLHIV cohort which is aging, and there is a significant shift to all age group, and therefore we are going to experience the comorbidity of age-related NCDs and HIV. And this is our uncharted territory. During HIV programming, we were all focusing on HIV prevention treatment. Now we need to have a paradigm shift. And thanks for the predecessors for presenting that. And again, as I've mentioned, NCD, non-communicable diseases, are threat to HIV care continuity. They are a threat in a sense that there will be treatment interruption, and we might be seeing a flare-up of incident HIV infection resulting from that. So our take-home message is that treatment, as all other previous speakers have spoken about, is the largest cost driver of the response. We need to focus on both prevention of HIV and prevention of NCDs, and when we do an integrated approach, there is a very minimal cost to that. And we are saying that to minimize the impact at population level, integration is a must. Thank you.
Thank you so much, Dr. Prosper, on HIV and aging and the NCDs related to that, and including some information about the cost. So may I take this opportunity to welcome all our panelists. Please take your seat. And we will transition to our Q&A session. Once again, I had been inviting our audience to please write down your comments or thoughts and raise your hand for my colleagues to collect for compilation. So I will invite Dr. Ola to please read for us the first set of 3 questions, perhaps. How many?
If it's okay if I can read all of them.
Okay. So let's be prepared to capture. Karibu, Dr. Ola.
Thank you for the questions. I had to paraphrase some of them, but I've captured your message. So with regard to prevention, the questions are, what are the current barriers to develop the needed infrastructures? What can be done to change this? What can we do to encourage government, donors, insurance to fund prevention of NCD at primary health care levels? Dr. Ismail, you had a number. How health insurance plans to cover prevention and promotion of wellness programs, to cover oral health, to cover nutritional services, psychological counseling coming from chronic stress, and how you plan to promote behavior change at community level, especially in poor communities. And one made a comment that there is no immediate money to be made in prevention. And the comment is, we require government intervention and policies to get the money. This is one of the comments. Then we have questions on reaching the recipient of care is saying, what is your plan to reach service users who are not coming to facilities with those services that you are providing? How do we reach them? And then we have some on the demo study. Are there any challenges observed concerning pill burdens among recipients of care? Looks like the adherence like 19%. And also, toward the universal health coverage, what is your thought on the modality of health financing which can address the existing gap and also ensure sustainability of equality, equity, and availability of services through UHC? I hope you're able to capture them.
Yes, thank you so much. And we're still gathering additional questions. If you have them, please feel free to write additional ones. Do we have a first responder? That evening.
So I'll repeat the question, then get to the answer. How health insurance plans to cover, number one, prevention and promotion of wellness programs. Number two, oral health. Number three, nutrition service. Number four, psychological counseling resulting from chronic stress. So health insurance companies right now are willing to invest on the wellness because this is the only way for them to control the expenditure or to control claims. Without preventing, you'll end up paying for treatment. So they don't have any other option than to invest on the wellness. And currently, at least each private insurance company holds a wellness department which is dedicated in delivering different wellness program. So yes, prevention and promotion of wellness programs has been integrated currently in the health scheme and medical schemes that are being delivered out there. And just to add on that, psychological counseling resulting from chronic stress is also being covered currently. I know from the conventional or traditional medical insurance, this was not part of it, but now due to the demand and the need, this has been also been incorporated. Another question was how promoting behavioral change at community level, especially poor community. I'm not sure. What are the current barriers to develop the needed infrastructure? That's not mine. Edu, okay. Then, how promoting behavioral change at community level, especially to poor community? Number one is just the awareness, the education and awareness. These particular forums and this particular research that we've seen here are impacting the local people, those who cannot afford even the insurance. Professor Stella mentioned, Dr. Redemptor mentioned that the insurance penetration is less than 1%. So if the insurance funding is less than 1%, then the only way that you can control this funding or reduce the funding from the government is through promoting behavioral change at the primary level before you reaching the tertiary, and also educating and creating awareness. Thank you. Oh, there was.
Thank you. Dr. Redemptor, would you like to respond next?
Thank you very much for the question. I have two questions, and I think here I have a question for Dr. Njau. So the first question is, from the demo health facilities that we showed, any challenges observed concerning pill burdens among the recipient of care? So just to show you that we started this demonstration project earlier this year, and we have 3 months follow-up, and then when they are stable, they come to for 6 months follow-up. And then it is aligned with their HIV visit. For those who are familiar with the HIV care and treatment clinic, patients who receive 6 months drugs actually get only 2 bottles, because in one bottle you have 3 months, and the other one you have another 3 months, thanks to the innovation by the pharmaceutical industries. And therefore, the drugs for the hypertensive, those who have been stable, we don't give them antihypertensive unless they have been stable. We also we align with that, but given that we cannot give drugs, antihypertensive drugs for 6 months, we give it for 3 months. On the other question of what about service users in the community, I mean, integration means you are actually providing person-centered services. So basically, you are providing services to that person and not to diseases. So once this person has stabilized, we do have outreach services for HIV. And this would be the next step for us. When we go out, we do screen them anyway. So screening is being done. The 98% I said we conduct screening, or 97% on average in our program, includes also those who are seen in the community. Now the next step would be to make sure that for those who have been confirmed to have hypertension, they also get their drugs. I think this is something we need. I think the issue of drug financing is another issue that we all as the government and stakeholders need to consider, but I like the analysis that Dr. Njao made that, you know, the additional cost is not as much. The next question was towards the universal health coverage. What is your thought on the modality of health finances which can address the existing gap? I really don't have an answer as Redemptor. I think this is a question to all of us here. We know that people cannot continue to do out-of-pocket payments if we really want them to get quality care. So we need to find alternative funding mechanisms. And our demonstration project is actually coming to an end. And we have been telling our clients that, you know, after this you'll have to continue whether with insurance or whether it is, luckily there are a number, 15% are being exempted because of the policy issue. So I think the policy that is in place needs to be used, that those who are exempt, who needs to be exempted should be exempted, but I think expanding the universal health insurance is the response to this. Thank you.
Okay, I have a question on what are the current barriers to develop needed infrastructure. How do we get the prevention on the agenda? I think prevention is something which is not fanciful, because when you tell somebody who is drinking a bottle of beer every day to stop it, or taking 3 Coca-Colas a day to stop it suddenly, you know, he's not going to like you. So when it comes to prevention, it has to be a multi-sectoral approach. And unfortunately, the risk factors which I showed you, only 20% are within the health sector. 80% of the risk factors or the environment in which the risk factors occur for prevention are outside the health sector. So unless you have a multi-sectoral approach, which includes the Ministry of Industry, Ministry of Finance, Ministry of Education, Ministry of Agriculture, and everyone sitting down together to put in a multi-sectoral approach, then only things will move. That's number one. Number two, the policies, appropriate policies for food regulations, for tobacco control, for alcohol control, and for, again, for the physical activity. Again, you find that basically those policies might be there. Like we as a NCDA, we did a desk review of all the NCD legislations which have passed through the parliament. This was about 14 years ago. There are 68 different legislations related to the NCD component which have passed through the parliament. But out of those 68, only 4 of them are being implemented. The rest of them are still within the legislation. So you see that the implementation has not happened. And now we are currently doing another review to see after 15 years what has moved from the parliament out into the laws and regulations. And probably we'll get a reply by next month, but there is hardly anything moving there. And the third thing is the media. I think the communication, the social media. I think people out into the rural areas, because our next epidemic is going to come in a rural area. You go to a rural area, previously, people used to walk to their farm. Today they call the boda boda, he comes to the home, you pick up your things, you go to the farm, once you finish, you call boda boda, he comes and brings you back. So the conversion of hypertension, diabetes and obesity, the rate of incidence is much, much higher in semi-urban and rural areas. So that's the next wave which is coming. And I think that's where the major burden is going to be. So unless we get our act together of having a multi-sectoral approach, building the right environment for exercise, policies, regulations, laws, mass media, everybody working together, this prevention after 10 years, we'll come back to this same health summit and we'll say prevention has not worked. And that's what it's going to be, because it's one of the most challenging component. And unfortunately, the amount of funding which is given into prevention is less than overall 5% of the curative care which you provide. And that's never going to work. So I'm glad that the insurance companies have started realizing, because it is hitting their belt. In the United Kingdom, for example, within the national health system, what they do is that if you are a GP, if you see a patient, you call his family, and when you detect a new person with hypertension, a new person with diabetes, you are given a bonus, because you are detecting somebody very early before they go into complications. So basically they are encouraging, so doing a prevention work is giving you a bit of a bonus rather than a curative work. And I think that's where the whole mindset has to change. Thank you.
Asante, Prof. Professor Stella?
Very much. I have picked one question related to the barriers for advancing this integration. As you have seen, I've shown a pilot or a demonstration study. Director Dr. Mbatia has shown the same. So in my opinion, I think we have to organize like centers of excellence, identify areas where they have to implement the minimum standards so others can come and learn. When we say clinical audit, it links with equality, and we should have centers where you can bring people to come and learn. Those centers can be organized within our regions. Yeah,
Thank you so much, Prof. And Dr. Prosper?
Thank you, my fellow speakers, but also the audience for your attention. I have 4 questions. One is, what is your plan to reach service users into the health facility with those services that we're providing? The second one is, with aging population, HIV and NCD, the rise. How well is the public and private sector prepared to offer quality geriatric care to prevent morbidity and mortality? And the third one is for sustainability and integration of communicable and non-communicable disease. What are the current sustainable ways planned to support the availability of NCD medication among recipients of care, as it is not ARVs? And the final one is, how does the government and other stakeholders work to equip medical student clubs with necessary funding, training, and tools to design effective NCD awareness campaigns? All right, thank you. So in no particular order, the plans that are there to reach those outside of the mainstream health services, these of course include the use of community structures, but also devolving the health facility. And this has 2 important things. One is it helps reduce costs, but it also decongests clinic to focus on really essential healthcare services. We have been speaking about this, and we have a dialogue on this. We continue to strengthen this community program so that we reach those who are not coming to the health facilities. Among others include the wellness programs for NCD, but HIV prevention for others. What are we doing as NASCOP to ensure and support availability of NCD care? And right now, as they've been presented by Dr. Mbatia and others, we are going through an learning and implementation phase, and from that we'll adapt those learning to scale. But again, as you have mentioned, that who is going to cover the cost? And I think I would go back to the message that came from the previous speakers, but also from myself. The most effective way to reduce cost and for a sustainable program is prevention, not only for HIV, but also for communicable diseases. And yeah, so we gain 2 things. One is we reduce the burden, but 2, as it has been mentioned, the cost is much lower, so we maximize efficiencies. That way, even universal coverage can be a realistic goal when we invest in those areas.
Thank you. Unfortunately, time is not on our side. We acknowledge that we've not addressed all your questions, but we will be developing a forum report that we will post on the THPS website that we will ensure all your questions are responded to. We will reach out to the speakers and get additional responses. If your question has not been responded to, please look out for the forum report within 2 weeks at the THPS website. As we come to concluding our forum today, I'd like to introduce a bonus guest speaker. Dr. Catherine Joachim is a seasoned public systems specialist with more than 20 years of hands-on experience in planning, management, and coordination of activities pertaining to both public and private health services in Tanzania. She trained as a medical doctor at Mbarara University of Science and Technology in Uganda and received a diploma in tropical medicine and hygiene from the Liverpool School of Hygiene and Tropical Medicine in the UK, and she did a Master of Science in Global Health Systems at Queen Margaret University in Edinburgh. As the head of programs and health system strengthening in the Ministry of Health, she provides strategic leadership for HIV, TB, and malaria national control programs and supports the coordination of stakeholders in these areas. Dr. Catherine has led a number of successful resource mobilization initiatives from prominent global health initiatives such as the Global Fund, PEPFAR, Gavi, the UN, and has enabled Tanzania to attain health outcomes. During her tenure as the head of Health Sector Reform Secretariat, she coordinated the health sector stakeholders in executing the health sector-wide approach SWAP. In this role, Dr. Catherine steered the midterm review of the Health Sector Strategic Plan 4 and the development of the next one, the 5th, and the preparation of the National Health and Policies Framework for Tanzania, where she managed to convene 16 ministries in the formulation of key policy issues that may influence health outcomes. Please join me in welcoming Dr. Catherine to help us conclude our forum this afternoon.
Good evening, everyone. Actually, this is a tough assignment for me after hearing the views from our distinguished panelists. But however, I'm going to just give the remarks to end this session. As we come close to the of today's panel session organized by the THPS, on what stakeholders from service delivery side, NGOs, private sector, but also from the government on the work that has been going through the country in the efforts to end the communicable diseases, but also to address the challenges that the country is currently facing in the reducing the burden of the non-communicable disease through lifestyle modification, integration of communicable and non-communicable diseases, but also we have had best practices on care and treatment, and also in the prevention programming. We also had how evidence from the Kibongoto has demonstrated on e-learning that yielded ability of the healthcare workers to treat patients with both diabetes and the non-communicable diseases. Communicable diseases. The models and best practices shared by the Tanzania Diabetic Association and the THPS has given us an opportunity to see the power on how we can tackle the challenges we are facing today with the dual burden of communicable diseases and non-communicable diseases. As we move forward, it's clear that we need to continue prioritizing first the integrated prevention, care and treatment, monitoring and evaluation, but also the audits. I understand in both communicable and non-communicable diseases, we have audits framework. And from what was shared by Kibongoto, I think it's important also we go beyond prevention, care, and treatment, and we see what other supporting systems can be integrated. Secondly, we need to shift the financing. As you may recall, when Dr. Kaushik or Professor Kaushik was taking us through the financing landscape, you could see today much of the financing goes to the secondary and tertiary care. But based on what was presented by strategies, but also what was presented by Professor Kaushik, you could see we needed resources for prevention and mainly to support the areas, many areas. Actually, if you could go, we have those risk factors, we have those community programs that probably if the shift of resources could go to the primary health care, could support our communities in the fight against both diseases. Thirdly, is the sustainability question. As you could see with the HIV programming that Prosper has taken us through what is costing them, much of this financing, more than 90%, is coming from the donors community. So we need to think through on how we are going to sustain the gains that we've made. You've seen the incidences is going down, the prevalence is going down, but the NCDs is coming up. So we need to see how best we are going to sustain these good gains, but also understand how are we going to be more efficient, but also without forgetting the equity. So with this one, I understand when the global health initiatives such as the Global Fund, PEPFAR, when they're coming with resources, actually it comes with the information notes, the guidance. And when you go through those guidance, actually NCDs is not visible. So I'd like to urge whoever is here, I know we are all interacting with them. Probably when we are making this framework for funding, I think it's important to see how best we are going to embed NCDs, because when you look at in a long time, as was said by Prosper, if we don't address it today, actually, probably we might not meet the 2030 targets that are set for both non-communicable diseases and the communicable diseases. So I would like to end by thanking everyone for really turning up for this session, and I'm very proud. I've seen people from across all the stakeholders. I've seen the RMOs here. I've seen colleagues from the Global Health Initiatives, but those who are working the facilities, without forgetting the youth. I've seen also the youth in this session. Thank you very much for your dedication to work and make sure collectively we address the burden of communicable and non-communicable disease in Tanzania. Thank you very much for your kind attention.
Can we have a group photo, please? Should we stand up front or in the back? Can we stand here? Can we stand in the front, please?